I'm from Barcelona and from the Hospital de Santa Creu de Sant Pau. This hospital was set on 1401 and as a merge of 6 small hospitals that were set in the 12th century. So we have a long tradition in Barcelona. And before they were saying things about the Spaniards, and I have to say that we are still struggling with them. So you got rid in 1648, they got rid before, and we still have not got rid of them. But anyway, we may be or not. We don't know. They are now menacing with tanks and things and funny things, so we'll see. But we can still find all together on the ESC meeting on August. There won't be tanks still, but anyway. So my talk will be with all those 3 different points. We do have experience with inhibition of PCSK9 in Spain. Of course, the Spanish government has issued several recommendations. Those recommendations then have to move on to the 17 different communities, which is a mess, of course. And every single community have their own recommendations. And therefore, I will talk about the Spaniard recommendations and then our recommendations, and then some conclusions. So pivotal studies during last year, we have got 2. But before going to this, I would like to say that during last decades, we've been struggling in the primary prevention and in secondary prevention, and we've been fighting with all cardiovascular risk factors. And actually, we've enhanced the prognosis of those of patients, both in primary and secondary prevention. And despite this, we've got a problem, and this problem is the one that is in red: obesity and diabetes. So all that we are gaining from the treatment of different risk factors, we are losing a bit with obesity and then with diabetes. So inhibition of PCSK9 is important. Cholesterol is causal to the disease, but we are facing a horrible disaster within the ongoing decades. Now, oops, not this one. In Spain, we've got the Spanish Society of Cardiology. We've done several registries, and as we are close in the peninsula, so I thought it would be interesting for you. And what we were observing is that treatment is being enhanced. We are treating every year with more intensity, and actually, the last registries we see that statins are prescribed in at least 96% of patients in the outpatients clinics in cardiology. So it's reasonable, and moreover, the dosages of those statins are increasing, and therefore we can say that now we are treating with high intensity statins, as if to say from the American guidelines. And then there is less and less patients with no statins, with no treatment, or with low intensity treatment. So we could be happier with this. But then we go to registries, for example, the Aspire, or the results of those registries again, and we see that we only achieve goals of treatment in our patients in about 22 to 33% of patients, which means that only 1/5 to 1/3 of patients are below 70. This is to mean that the other major percentage of patients are absolutely uncontrolled. We know the problem, we know that cholesterol is causal, we know how to deal with the drugs, prescription is easy, but we are failing completely in the treatment. And this is not a problem of Spain, that could be, but it is not, because it's an European problem and also an American problem, and actually a planetary problem. So we all know guidelines, we all know goals, but we are not dealing good enough. And with the new guidelines, I would like to stress that finally, both in primary prevention and secondary prevention, in family hypercholesterolemia or in secondary prevention, we have finally recommendations dealing with inhibition of PCSK9. So what we've seen up to now is that intense treatment for lowering cholesterol may reduce plaque burden. And there was just one major trial showing benefit with a non-statin product, which was ezetimibe, with the improved at the last month in 2014. So as an abstract, there was the ACCORD study with fenofibrate that failed. Other treatments as the omega-3 also failed. With niacin also failed because there were several issues with design of the study, the power of the study. But anyway, it failed. And with dalzetrapib, it failed as well, as mentioned previously by Prof. Jukama. Hopefully, anazetrapib will be different. So we'll see. We'll see the NNTs and, well, we'll see when they present the whole study. But then what we all know is that from Mendelian studies, whenever that we have a mutation that lowers the LDL level, this will be beneficial for the carrier, whatever the mutation involves, both LDL receptor or PCSK9 and PCSK1 receptor, whatever it involves, it will be beneficial for the carrier. And although the reduction in LDL will be small, the impact on cardiovascular prognosis will be very, very important. And that's because the carrier is exposed to less cholesterol just from the beginning. Whereas with statins, we are doing, with hypolipidemic treatment, we are doing a big impact, but for a very limited period of time. And this is so also for disease regression that was shown with the asteroid and with the reversal. So this is the background, and then GLAGOV appeared. GLAGOV is a study that was published last year, and this is the scheme of treatment. There was a coronary angiogram that was driven by clinicians. It was not for research, but anybody that was referred to the cath lab, then they were asked to be involved in the study. And there was an IVOS. There was an IVOS, and then they repeated the IVOS several months after. It was about 18 months after the first IVOS, which is very good from a research point of view, but it's not studying atherosclerotic involvement. It's just studying several centimeters of a single artery, which is maybe a limitation of the study, as we will say afterwards. Anyway, they were randomized to placebo or to evolocumab on top of the normal treatment with statins usually. Those were the baseline characteristics. They were rather usual patients. In our hospital, our average age is about 300 years old, so they are much older than those ones. They are almost 60 years old, and in average, we have 70 to 75 probably. Male gender, 72%. They were overweighted, only 21% of diabetes. In our institution, we are in about 30 to 35% of diabetes. And smoking 23%, baseline statin use, high baseline statin use, with high intensities in at least about 60%. And baseline LDL levels, there were only 92 milligrams deciliter. Of course, evolocumab reduced LDL. I mean, this is obvious. And the reduction was an important reduction at about 60%. And this had implications on several particles, as it can be seen here. Well, it cannot be seen but anyway, it lowers LDL. It lowers, no, the other one wrong. It lowers LDL, it lowers triglycerides, it lowers several particles that are interesting to be lowered for the first time, APO, LP(a) also. So that we had several interesting effects on lipids, and this had an implication on plaque regression, both in the primary endpoint of the study and in the several secondary endpoints of the study. Percentual plaque volume was reduced. Plaque volume itself was also reduced. And in accordance with prior studies with statins, we could see regression from 60 to 70 mils deciliter down. So patients below 60 were more likely to regress plaques. Funnily enough, curiously enough, those are the results in bars more clearly shown. But then there were patients that they did not regress. And those, I think that they're very, very interesting patients. Those patients that were with low LDL but no regression. LDL is causal to the disease, but then lowering LDL is not, in at least 1/3 of patients, would not be enough to regress this disease. And this, I think, it should have to be investigated more deeply. All pre-specified groups were exactly the same. They were behaving exactly the same. All the bars are in the right side of the equation. And there were less clinical events in people and in patients treated with evolocumab, but of course, this study was not powered to have any relevance from a clinical point of view, but just from an angiological point of view. For the clinical point of view, was to come Fourier several months afterwards. If we focus on patients with baseline LDL cholesterol below 70, those patients were the ones that regressed the most. And this is a finding that was somehow striking, because one would think that in the baseline, the highest you have the LDL level, maybe the most that you would benefit in terms of plaque regression. But it was not. The ones that regressed the most were the ones that had the baseline LDL below 70. This could be a topic of discussion afterwards, but it is that it was. But then, limitations of the study, it was a highly selected group of patients, and 30% of patients were lost to follow-up. But it has to be said that this 30% is very low in IBOS studies. There are patients that have to repeat another cath despite being asymptomatic. So therefore, is a low figure. And of course, it was not a clinical study, and therefore we had to wait to Fourier to see any clinical relevance. And again, this study only assessed a few centimeters that were prearranged, preset in the index cath. And therefore, all the other arteries and all the other centimeters of the arteries were not assessed. Then Fourier was presented in the ACC in Washington. The objectives of the study was, of course, in patients with cardiovascular disease, with peripheral artery disease, with prior strokes, or with ischemic heart disease that were already treated with statins. They assessed whether adding evolocumab reduced the incidence of major cardiovascular events. They examined the long-term between brackets, because there were only two years and a half, the long-term safety and tolerability of evolocumab, and they investigate the efficacy and safety of achieving unprecedented, there is a mistake, unprecedented low LDL levels, because there was a significant percentage of patients that were with LDL levels below 20. The study design is about more than 27,000 patients that were included. Most of them were ischemic heart disease. There were much less with stroke or with peripheral artery disease. And they were randomized to evolocumab or to placebo. The objectives was efficacy, safety. Efficacy, the primary endpoint was composed of cardiovascular death, MI, stroke, hospitalization for unstable angina or coronary revascularization, and a key secondary objective that was CV death, MI, or stroke, heavy, as if to say the heavy part of the primary endpoint. For safety, all the adverse events, serious adverse events, of course, also with interest for cognitive and for muscle. In fact, there was a sub-study that was pre-specified. It was the Ebbinghaus. There were several thousand people that they underwent a very, very thorough cognitive assessment in order to check whether these drugs with those low LDL levels had anything to do with cognitive or memory impairment, which we will see then. So the median follow-up was 26 months. And as we can see, there was a relatively low figure of drug discontinuation. And there was a very, very low figure of loss of follow-up. So if we have in mind that we had more than 27,000 patients, there were only 18 that were lost. So it is very good. The trial was performed very good. The baseline characteristics can be seen here. Basically, most of them, as I said, 81% had prior coronary heart disease. All three, they add up more than 100 because a single patient could have different parts of the body involved with atherosclerosis. In here, patients are more likely to the day-to-day clinical practice, hypertension, 80%, almost 40% in diabetes, and current smokers more than 1/4. And the statin use, almost 70%, they were on high statin dose, and there was only 5% of ezetimibe use before entering to the study. LDL, again, was 92. So it's a low LDL, and despite this, we will see that that the authors had very significant results. Now, reduction of LDL, as it can be found in the Osler program and in the GLAGOV, was at about 60%, which is obviously a good result. And the primary endpoint that was cardiovascular death, myocardial infarction, stroke, hospitalization for unstable angina, and coronary revascularization was lowered 15% with highly statistical significance, and an absolute risk reduction of 2% on top of statins at a reasonable high dose. And the key secondary endpoints, the hard endpoints, cardiovascular death, myocardial infarction, and acute and stroke, it was also reduced by 20%. Those results were encouraging, but then assessing the different compounds of the endpoint, there was no effect on cardiovascular death. And so this was a sort of, it was not shocking because we will see, but it was as being so positive with last trials and impacts such as empagliflozin that was unexpected an impact on mortality, and then lowering a 60% LDL cholesterol and no impact on mortality was a sort of a disappointment within the presentation. But there was a reduction in myocardial infarction and stroke. In the publication, in the appendix, we can see that all 5 types of myocardial infarction are extremely properly addressed and defined, but there is no depiction of what sort of myocardial infarction is reduced. And therefore, maybe it could be reduced myocardial infarction in association with revascularization, which are myocardial infarctions that have very little to do with outcomes, instead of a STEMI, a new STEMI, for example. And hopefully it will be published, but not yet. So here we can see the hazard ratio reductions, and of course there's nothing in CV death of any cause at the lower part of the table. And in all key subgroups, most of them are in the right side of the graphic, and there is no P4 interaction in any of the different pre-specified subgroups. And a very interesting slide is this one. There is this landmark analysis, the first year of treatment and then the second year of treatment. In the first year of treatment, we have reductions of relative risk of 16%, but then on the second year, this reduction is about 25%, which is biologically plausible. We are lowering LDL, we are exposing those patients to much lower LDL levels, and this is working, is ongoing. In diabetes would be as, for example, analogs of GLP-1 that are slower in action in terms of they involve atherosclerosis, and then to have any good results, they have to wait more than, for example, glyphosines that have a much quicker result. So therefore, for this key secondary endpoint, second year had a much important reduction, and that was so for fatal MI, non-fatal and fatal MI and stroke. There was a reduction from 19% to 33%. This, to me, makes me think that if follow-up would have been longer, probably we would have had results on mortality. And actually, there is a prolongation of several thousand people involved in the Fourier that are being followed up, extended to 5 years in order to check whether there will be results on mortality. But then, if we go back to any trials with statins, and we compare in black the results of the CTT trialists at 2 years point time of follow-up, results on major coronary events, stroke, coronary vascularization, and major vascular events are exactly the same, very, very similar to the ones that were obtained with the Fourier. So therefore, any studies with statins, if we cut follow-up at 2 years, we have exactly the same figures as we do have in Fourier. So, as Prof. Fuster said, probably future of those drugs are more brilliant than actually they were when presenting the results of the study because of the lack of effect on mortality, but probably due to the short follow-up and maybe because of the type of events that were gathered with the follow-up. This, of course, all the safety concerns were around regarding the low LDLs, myalgia, myopathies, cognitive impairments, and so they were absolutely ruled out. There were exactly the same side effects in both arms, both in placebo and evolocumab. And therefore, as a conclusion for the Fourier, there is a LDL reduction of almost 60% that is consistent through all the trial. The median achieved was 30, which may seem to be extremely low. But then if we think about babies in the Occidental world, when they are born, they are about 30 to 40 in LDL. People in the Alaskas, in the Amazons, in Africa, etc., they may die because of other things that may seem exotic to us, but they don't die because of cardiovascular disease. And actually, in the same Congress, the same meeting, they presented the PSIMA study. They brought a CT scan to the Amazon, and they studied a population in there, and they showed that the LDL levels were much lower. They did about 16,000 steps a day, which is 6,000 steps a day for the Americans. So there is a big deal of differences. The incomes of calories is much lower. I won't explain the diet because it was somehow, no, not for us, for our taste. There were funny things hanging on that, but anyway. And then the vascular age of a male, 70-year-old male, was exactly the same as a 42-year-old male in America. So they were 28-year-old younger from a vascular point of view. And that was, among others, because of activity and because of cholesterol levels. So, other conclusions: the drug was well tolerated, was safe, and the Ebbinghaus, which was the cognitive study for the Fourier, and those are there were about 2,000 people that were enrolled in the study, and basically, to be quick, after 20 months, there were no difference whatsoever in any of the different tests that were really long. When they presented the Ebbinghaus, it was, we almost felt slept because it was so based the magnitude of variables that were gathered in order to check any cognitive abnormality. And this was so even for cholesterol levels below, LDL cholesterol levels below 25. So, well, what's the Spanish experience? It's basically the opportunity is here. We have LDL cholesterol levels that are, well, there are loads of windows for opportunities to enhance treatments. And those are the recommendations of the Spanish government. The Spanish government said, whenever you have familial hypercholesterolemia or secondary prevention for heart disease, and cholesterol is above 100, LDL cholesterol is above 100, and the patient is with the maximal tolerated statins treatment, then it should be on PCSK9. Of course, this is what the Spanish government says, but then this goes to the different communities, and the communities are the ones that will have to pay for the treatment. And the Spanish government, of course, didn't give any €1 to the different communities, and therefore the community said, okay, fair enough. You're so generous, you will be treating about 30% of the population maybe with ischemic heart disease, but you are not giving to us any euro to do this. So, well, in between these political funny things, in the Spanish Society of Cardiology, we did several recommendations, and actually they were similar in the sense that for secondary prevention, there was above 100, with two exceptions. There were familial hypercholesterolemia and people with recurrent coronary syndromes, those were recommended above 70 in order to lower the LDL cholesterols at about half, as mentioned in the clinical guidelines of the ESC, and in primary prevention, those above 130. So those were the figures. And then in Catalonia, well, there were different things. Again, in secondary prevention is about 100 if you have ischemic heart disease and one or two other or more risk factors. If you don't have any risk factors but cholesterol and you have chronic ischemic heart disease, then it will be refunded when you are above 130. And in primary prevention, it depends of what sort of family hypercholesterolemia do you have. If you're homozygotic, heterozygotic without ischemic heart disease, you will have different thresholds. But of course, in order to be dissuasive, whenever you want to prescribe those drugs, you have different, within the same screen, different button, and then it opens a series of windows that you have to fill in, and you have to begin and fill in to have a registry of the whole of all patients that are with those medications in Catalonia, in my case. So all those data they are gathered, and hopefully we will see some data on the use of these drugs within 1 year. Every hospital organizes this prescription in different modes. For example, in our hospital, there is a commission that is they meet every month to check all the new indications to see whether they are according the guidelines. Which, I mean, and this is of course because of the price. It's nothing else. Although there is a study that has been published about 1 month ago in cost efficacy in Spain, that with the current prices, and now they are getting a bit lower, and that they are cost effective. And I will present a clinical case. This was my first patient in February 2016 that was on the drug. He's a 50-year-old man. He has a familial combined hyperlipidemia with high LDL. This is the family tree. And his mother had a first myocardial infarction at age 32. His first myocardial infarction was at age 32 as well. And his history of ischemic heart disease is a bit tough. His debut was in 1999 with a non-STEMI. And since then, he's done several non-STEMIs. ejection fraction is about now at about 45%. And in 2005, he had a sudden death. He was resuscitated on the street and then brought to the hospital, to other hospital. It was not ours at that time. He came to our hospital in 2013. And, well, he's gone through several, of course, he had an ICD implanted. And since then, he's got ablation of epicardial ablation and endocardial ablation, left endocardial ablation of ventricular tachycardia. Now he's doing reasonably well. But on 2015, he had 2 or 3 admissions for non-STEMIs and unstable angina with several stentings. Those are the figures of LDL. I have to say that he had 2 episodes of rhabdomyolysis with different statins in 2001 and 5. The second one with acute hemodialysis because of kidney failure. And when I began, well, of course, he also had itching with, I would say, niacin and lorapipran. And when I received him, well, he was doing with very heavy muscular pain. He could not go up one stair of one flight of stairs because of the pain. And those are the blood test in 2015. His LDL levels were 154. He was on pitavastatin 1 milligram because he couldn't bear anything else, and with ezetimibe. So then we began on February 2016, and 3 months later, he was was amazing. He's probably in a PCSK9 mutation, but of gain of function. And well, his LDL was 12, actually 13 if you want to round. He was 13. We were all happy. I was extremely happy. He was almost in tears, and with his wife. It was the first time in his life that had those amazingly low LDL levels. And well, we sat in a conversation and we said, we will stay here because you've been last year with 2 or 3 admissions because of acute coronary syndrome. And within 4 to 6 months, a new blood test, and we'll see if you're still here. And then we will begin to decrease medication. And then, well, we did it like this. We put out ezetimibe and then pitavastatin, and now he's only with evolocumab, and he is in 40-something. He's over about, he's 43, yeah. So with no muscle pains. It's a sort of, I mean, he's intelligent, unluckily for him. And this was because he was taking the pill of pitavastatin because he knew that he needed pitavastatin because it was the only one that could bear at the lower dose. So since February 2016, he's not had any new admissions, which is a big thing, and no new ablations of VTs. So he's doing reasonably well. So as conclusions, I think that those 2 first points in the guidelines from the ESC are absolutely key. Elevated levels of plasma LDL cholesterol are causal to atherosclerosis, and reduction of LDL cholesterol decreases cardiovascular events. As was said before, having a high HDL may be good for your health, but enhancing HDL may not, which is different. We do not know which HDL we are increasing, 1, 2, 3, peroxygenases, yes, not. So HDL is an extremely complex family of different molecules, and therefore LDL is a goal to be attacked. We now have enough information to think that normal LDL levels in the human beings probably are about 30 to 40. In clinical practice, we still do not achieve the goals that we have ourselves set to accomplish. And we still don't have any nadir for LDL cholesterol. Of course, I think that LDL cholesterol of 0 would not be that good. as in ischemic heart disease, heart rate, the lower the better, maybe. But I don't know anyone with heart rate 0 that is happy. So, but anyway, below 20 is still safe. And this man was at 12, 13 for 6 months. He's doing well. And actually in Italy with the ApoB, the ApoB1, there are families in Italy that have very, very low LDL levels. They are not stupid. They are not suicidizing every day. They are not broken legs. And so they are doing normally. They are normally and they are dying normally, but not from cardiovascular causes. So inhibition of PCSK9 is safe. It is well tolerated. It lowers significantly cholesterol, LDL cholesterol, but also Lp(a) and triglycerides, which is good as well. Glagov showed a regression in most patients treated with evolocumab, which is interesting, but there was still this third of patients that did not regress, which I think that from a physiological point of view it's more interesting. Glagov extended benefit to 20, in Fourier, again, to less than 25. And therefore, well, there is a reduction in the primary endpoint. There is no reduction in mortality because probably the length of follow-up, I'm convinced that we will see a reduction in mortality as well, because when we have a longer follow-up. And Ebbinghaus showed that there is no effect on cognitive function whatsoever with those drugs. So, muito obrigado pela sua atenção.